Pityriasis rosea, a well-known skin condition. Many people worry when they see its signs. But what exactly is this condition? What causes it? What are its symptoms? Is it a long-term chronic disease? Or is it just a temporary condition that fades on its own? When it goes away, does it leave any marks on the skin? Is it contagious? Can it spread from one person to another? What are the treatment steps doctors usually recommend? And what are the most important care tips for someone who has it? Stay with me, and let's explain everything in simple, clear terms. Peace be upon you. I'm Hussein Lotfi, and you're watching the Octopus-Pharmacist channel. Welcome to a new episode of From A to Z Derma. At the start, here are the titles we'll cover in today's episode. If you're looking for a specific topic, you can rewind the video to the second minute. But if you'd like to know everything about Pityriasis rosea, stay with me from the first minute to the very last. As usual, let's begin with a quick overview and talk briefly about the condition and learn a few key points. First, what does the word pityriasis mean? It refers to fine flakes or scales like powder or dust on the skin. This tells us that the spots that appear will have very light peeling or scaling. Second, what does rosea mean? It comes from the word for rose or flower, and it refers to the light pink or rosy color of the rash on the skin. Third, what is the main cause of this disease? In fact, it's considered an autoimmune condition. This means that the immune system, which normally protects us from bacteria, viruses, and parasites, sometimes becomes confused and mistakenly attacks the body itself. In this case, the immune system targets the skin, which leads to visible symptoms. This is what we call an autoimmune skin disorder. So, what triggers this immune reaction? What are the reasons the immune system turns against the skin? First, after certain infections, especially respiratory infections. For example, a person may have a mild viral illness with a sore throat, runny nose, or slight cough. The infection clears up, and then 1 or 2 weeks later, the symptoms of pityriasis rosea appear. Second, exposure to cold weather, a very common and often more intense cause. Cold seasons can affect hormone levels and disturb the immune system, which may lead to the appearance of the disease. Third, certain medications. Examples include metronidazole, clavulanic acid, and isotretinoin, among many others. In some people, the immune system sees components of these drugs as foreign substances. It starts attacking them and also attacks the skin, leading to the symptoms of pityriasis rosea. Fourth, after certain vaccinations. For example, after vaccines like HPV, BCG, or diphtheria, the immune system may become activated and overreact, once again, mistakenly attacking the skin. So now we understand. The disease appears when the immune system malfunctions and reacts incorrectly, especially after infections, cold exposure, medications, or vaccines. But what are the skin symptoms of pityriasis rosea? The first and most recognizable sign is the appearance of a single large spot. This is often called the haro patch. It's typically between 3 to 10 centimeters in diameter and has an oval or round shape. The patch is pink in the middle with a darker red border. It may appear on the upper chest, back, or abdomen, usually below the neck and above the waist. The surface of the patch has fine, dry scales, very light peeling, like a sprinkle of powder. That's what the name refers to. After about 2 weeks, smaller patches begin to appear, similar in shape, but smaller in size, about 0.5 to 1 centimeter. These new spots spread across the upper and lower body. But keep in mind a very important point. These smaller spots don't appear on the face, scalp, palms, or soles. So if you see spots in those areas, the diagnosis may be something else. What else should we know? Yes, the disease usually begins with the haro patch, and around 75% of cases follow this pattern. However, the haro patch itself may be so light and subtle, the patient may not even notice it, and may only seek help once the smaller patches start to spread. Next, is this disease self-limiting? Yes, In most cases, it goes away on its own, usually within 6 to 8 weeks. The symptoms disappear without any treatment. But in some cases, it may last longer, sometimes 3 to 6 months. And in rare cases, it may disappear and come back again. This may happen once a year or more, especially in the spring or autumn. That's the general behavior of this skin condition. And now you understand the basics of Pityriasis rosea clearly. Second title, and it's a very important one. What are the most important skin conditions that could be confused with Pityriasis rosea? There are two very common diseases that may look similar. The first one is a type of psoriasis called guttate psoriasis. This is a special form of psoriasis that often appears in children, usually after a respiratory infection. And this is the first condition that could resemble Pityriasis rosea. Guttate psoriasis usually shows up on the chest or back, and these are also areas where Pityriasis rosea can appear. The word guttate actually means drop-like because the spots appear as small, tear-shaped lesions on the skin. By their appearance alone, these spots can closely resemble those of Pityriasis rosea. But pay close attention. Guttate psoriasis usually presents as small, hard, drop-like patches, and it tends to appear suddenly, although it's rare in spring or autumn, just like Pityriasis rosea. So, how do we tell the difference? First and most important clue, check the texture of the lesion. With guttate psoriasis, the spot feels rough, thick, and scaly. But in Pityriasis rosea, the scale is usually very fine and light, not as thick to the touch. Second clue, in Pityriasis rosea, we often see a large patch appear first, the harrow patch, followed by smaller ones. This large spot does not appear in guttate psoriasis. Third clue, guttate psoriasis spots are usually hard and thick, but in Pityriasis rosea, the scaling is light and delicate. However, be careful. In some mild psoriasis cases, the scaling might seem light too, so this point alone is not enough to confirm the diagnosis. So, based on these three main points, we can usually distinguish between guttate psoriasis and Pityriasis rosea. But what if there's still doubt? In that case, a skin biopsy is done. A small sample is taken from the affected area and examined under the microscope, a method called histopathology, which clearly shows whether the condition is psoriasis or pityriasis. The second condition that can be easily confused with pityriasis is tinea corporis, a type of fungal infection that affects the body. Now, as we mentioned before, tinea comes in many forms. The one that affects the body's surface is called tinea corporis, and it usually appears as circular or ring-shaped patches, which can resemble those of Pityriasis rosea. How can we tell them apart? You can use 4 or 5 simple clues that make it easy to distinguish. First, look at the patient's history. In pityriasis, we usually find a recent viral infection, vaccination, or drug exposure. But with tinea, the causes are different. There are 3 main ways tinea spreads. 1. Direct contact with an infected person. 2. Contact with animals like cats, dogs, cows, or sheep. 3. Autoinoculation, where the infection spreads from one body part to another, such as from between the toes to the chest. Second clue, observe the center of the lesion. In both conditions, the rash starts from the center, but in tinea, it slowly expands outward, while in Pityriasis rosea, the shape usually remains the same. Third clue, over time, the center of a tinea lesion clears up, a process called central resolution, leaving a red, raised border. But in pityriasis, the central area usually remains uniform, without clearing. Fourth clue, tinea can present with 1, 2, or multiple patches, just like pityriasis. But as tinea progresses, the patches may merge together, forming larger areas. This merging and expansion doesn't happen with pityriasis. Its lesions stay the same size and number. Fifth clue, check the edges of the lesion. In tinea, the border is often raised, scaly, and sharply defined, with some itchiness or irritation, a classic fungal reaction. With pityriasis, the border is also visible, but not as raised or reactive as in fungal infections. Sixth clue. In Pityriasis rosea, we often see a harrow patch first, a large single lesion, followed by smaller ones. This pattern does not exist in tinea infections, regardless of size or number of patches. Tinea always follows a fungal growth pattern. Still unsure? No problem. The easiest solution is to take a skin scraping from a lesion and examine it using a fungal test, KOH prep. If fungal elements are present, it's tinea. If not, then the diagnosis is more likely Pityriasis rosea. The third title, and the one before last. What are the steps to treat Pityriasis rosea? In fact, we have two main scenarios. First, if the condition is still in its early stages and things are going normally, we start with basic treatment steps, and usually the skin responds very well. Second, if we try these basic steps and there's no improvement, or if the symptoms disappear and then come back again, this usually means we're dealing with a resistant case, and we need to move on to more advanced treatment options. Let's explain these in order. Step 1, basic treatment. We start with 3 essential steps. 1, moisturizing and skincare. This means using fragrance-free cleansers or gentle soaps. The brand doesn't matter. What's important is that the product is free of perfume and safe for sensitive skin. When washing the skin, avoid using rough cloths. They can cause irritation. And during drying, pat the skin gently instead of rubbing. After drying, apply a fragrance-free moisturizing lotion, again, suitable for sensitive skin. Why do we insist on fragrance-free? Because fragrances can increase skin irritation and sensitivity, especially in inflamed skin. What's the role of moisturizers here? Moisturizing the skin helps speed up tissue repair and skin regeneration. It also helps prevent discoloration after the rash heals, a condition known as post-inflammatory hyperpigmentation, PIH. This means that after the inflammation, the skin color may change, becoming darker or lighter than before. What causes this? Since this is an autoimmune disease, the immune system may affect the melanocyte cells, either overactivating them, leading to dark spots, or damaging them, resulting in lighter patches. That's why keeping the skin hydrated during recovery is so important. 2, topical cortisone, steroid creams, or solutions. There are several forms of topical corticosteroid available, like betamethasone, hydrocortisone, or mometasone. If you're using a cortisone solution, it can be mixed with lotion. Use around 15 milliliters of steroid with 200 to 250 milliliters of your lotion. Important warning: topical corticosteroids should not be used for more than 1 month without medical supervision. Long-term use can lead to side effects like thinning of the skin, atrophy, visible blood vessels, skin discoloration, excessive hair growth, weakened local immunity. So what's the benefit of using cortisone? Cortisone helps reduce immune overactivity, which is a root of the problem in autoimmune conditions like this. Afraid of cortisone? You can use calamine lotion instead. It's soothing, reduces itching, and helps calm inflammation. But calamine can dry the skin, so it's best to use newer formulas that combine calamine with moisturizers. However, in most cases, topical cortisone remains the most effective. Apply once or twice a day, especially after bathing and drying. 3, antihistamines. These are used to help relieve itching. You can give a non-sedating antihistamine in the morning from the 2nd or 3rd generation, so the patient can stay active without drowsiness. At night, you can use an older generation antihistamine to help the patient sleep better. Now, what if the basic treatment works, but the condition comes back, or it doesn't improve at all? In that case, the patient needs to see a dermatologist because this is now considered a resistant case. Step 2, advanced options for resistant cases. Here, the dermatologist has 3 main options. 1, phototherapy, ultraviolet light treatment. UVB sessions may be used to suppress the immune system in the skin. Since the condition is autoimmune, UV light can help stop local immune attacks. However, phototherapy only works on the treated areas. The untreated parts of the skin may still develop new spots. Another issue, after phototherapy, many patients develop strong pigmentation in the treated areas, so it's not used as a first-line treatment, only in resistant cases. 2. Oral corticosteroids. This approach is generally not recommended. Although cortisone suppresses the immune system, using it by mouth can cause a rebound effect, where the rash spreads even more after stopping it, severe pigmentation changes, and other systemic side effects. So even though it may seem logical, oral cortisone is usually avoided in this condition. 3. Antiviral treatment. Some dermatologists and some medical textbooks recommend starting with this step in certain cases. This option is only effective if the condition begins immediately after a viral respiratory infection, which is one of the known triggers for Pityriasis rosea. In this case, antiviral medication like acyclovir may be given, usually 800 milligrams to 1 gram every 5 hours, for about 1 week. But here's the key. Antivirals only help if started in the first week of the skin eruption. They can stop the rash from spreading, reduce its intensity, and prevent long-term post-inflammatory pigmentation, no matter which advanced treatment the doctor chooses. The basic skincare steps: gentle washing, moisturizing, avoiding perfumes, cortisone or calamine if needed, remain essential and should continue throughout. The fourth topic: what are the most important instructions that the dermatologist should give to a patient with Pityriasis rosea? We have 4 or 5 simple instructions, but they're extremely important. Let's go through them one by one. First instruction: the patient must understand that Pityriasis rosea is a self-limiting disease. That means it goes away on its own without needing aggressive treatment. As we mentioned earlier, the rash usually lasts between 6 to 8 weeks. So, why do we give treatment? To speed up recovery, relieve discomfort, and prevent skin damage or dark marks afterward. Second instruction: the patient should be aware that this condition can come and go. It may disappear, then reappear again later. This recurrence is normal, and in most cases, it happens during spring or autumn. It's important to reassure the patient that this is expected and not dangerous. Third instruction: make it clear this disease is not contagious. The person can live a completely normal life. They don't need to isolate themselves. They don't need to wash their clothes separately. There's no risk to their family, children, or partner. If another infection does appear, it's likely a secondary condition, not the original Pityriasis rosea itself. Fourth instruction: avoid scratching or peeling the skin with nails. Why? Because it can lead to skin damage, hyperpigmentation, or even secondary bacterial infections, especially from germs under the nails. That's why it's important to trim nails regularly, avoid picking at the skin, and wear soft, breathable, loose-fitting clothing to minimize irritation. Fifth instruction: avoid anything that might increase skin irritation or bacterial growth, such as wearing thick or tight clothes, using lotions or moisturizers with perfume, strong sun exposure or excessive heat, which increases sweating and irritation, using perfumed soaps or harsh chemicals on the skin. Stick with fragrance-free, gentle products, as we explain in the treatment section. Sixth and final instruction: there are many websites and online rumors that talk about specific foods that cause or cure Pityriasis rosea. But in reality, there is no scientific evidence for any of this. There are no specific foods that trigger or treat this condition. The patient can eat normally, but as with all health matters, it's best to eat a balanced diet. With these instructions, the patient will be informed, reassured, and confident in managing their condition safely, without unnecessary fear or confusion. The fifth and final point in today's episode: who are the people that pharmacists should never start treatment with, not even simple medications? These cases are what we call red flag cases, and it's very important to completely avoid treating them unless you're a specialist. Let's explain the two most important examples. First, pregnant women. Why? Because Pityriasis rosea is not a simple skin rash during pregnancy. Some of the medications, even the mild ones, can reach the uterus and may cause uterine contractions, which can lead to bleeding or even miscarriage in rare cases. That's why in pregnancy, this case should only be handled with the help of a dermatologist and an OB/GYN specialist, both working together. Do not treat this case alone, no matter how mild it looks. Second, people with immune system problems. Anyone with autoimmune diseases or immune suppression. We do not start treatment for Pityriasis rosea without a thorough medical evaluation. Why? Because Pityriasis rosea may look simple, but if the person is already immunocompromised, things can get complicated. What kind of people are we talking about? Someone who has had a transplant, heart, kidney, liver, etc. Someone taking immunosuppressive medications. Or someone with a diagnosed autoimmune disorder, like lupus, rheumatoid arthritis, or multiple sclerosis. Or anyone using long-term corticosteroids. In these cases, the skin rash could mimic Pityriasis rosea, but it might actually be something more serious. These patients must be referred to a dermatologist immediately. And that wraps up our full discussion today on Pityriasis rosea. I hope you found today's information useful and clear, and I hope it gave you new insight into a condition that many people misunderstand. If you enjoyed this video, please don't forget to like, subscribe to the channel, and share the episode with your friends. Your support helps us grow. And if you'd like to contribute, feel free to support us on Patreon, PayPal, or directly through YouTube. Until next time, good night and take care. I'm Hussein Lotfi, and this is Octopus-Pharmacist channel, from A to Z Derma.